Efficacy endpoints for oncology. Complete response CR. No detectable disease according to predefined response criteria. Now the terminology itself says complete response means there is no disease detected. Partial response PR is predefined reduction in tumor burden, commonly greater than 30% decrease in target lesion sum under RECIST 1.1. Now you can search this guideline RECIST 1.1. It is easily available in Google, so you can download or you can go to cdisc.organization website and you can download through your login credentials and sign in. It is very user friendly website. So this is what the threshold value is. Stable disease is SD, neither sufficient increase for PR nor sufficient increase or PD, right? Stable disease means it is stable, neither it has decreased or neither it has increased, right? Progressive disease PD is commonly greater than 20% increase in target lesion sum from nadir and greater than or equal to 5 millimeter absolute increase or new lesion. So progressive disease is something the condition of the oncology disease has worsened, right? That means the tumor has increased to certain threshold value. Here it is greater than 20% or some new tumors that has been developed. So PD is nothing but kind of a worst criteria where the tumors have increased. SD is nothing but no changes, neither it has decreased or neither it has increased. Partial response is some part of the tumors they have improved and the size of the tumors has reduced, right? And complete responses, there is no disease detected. So in a common layman's language, CR is good, PR is somewhat, SD is no change, and PD is worsen change. Now, primary efficacy endpoints, the number one is overall survival. It is calculated from date of death minus date of randomization. PFS is progression-free survival, which is calculated from date of disease, progression or death minus date of randomization, right? Now here the disease is progressed. That means the disease has increased, right? So you need to take that date or death. Now these dates will be mentioned in the CRF. Wherever any clinical trial is being conducted, these dates are very essential and it should be captured on case report form. ORR is the objective response rate, which is calculated by CR plus PR divided by evaluable patients into 100. Event-free survival, EFS, is defined as date of first predefined event minus date of randomization. Now what is event? In any clinical trial, especially in oncology, the event will always be defined in your protocol, and the same it needs to be incorporated into the statistical analysis plan. So don't worry too much whenever you see event free survival. So that event definition, like say time to success or time to failure or time to improvement or time to decrease, that event has to be defined in protocol and SAP. So based on that you can give the interpretation. Disease free survival, DFS, is date of recurrence, second cancer or death minus date of randomization or surgery. Now disease free, that means the patient got the second time cancer. The first time cancer was treated, it had gone, but it has reoccurred again. That means the disease has come back again, right? So in those situations you calculate this DFS for those patients who fall under this category of having second or third time cancer. Now pathologic complete response, PCR, is patients with no residual invasive cancer in specified surgical segments divided by patients assessed into 100, right? So all these are efficacy endpoints, especially in the general oncology terminologies which I'm trying to explain here is. And the specific oncology clinical trial what you will be working on will be mentioned in the protocol and the statistical analysis plan. So you need to check with the sponsor, but this is just the general overall kind of categories and the formulas which I am explaining here, which falls for all oncology clinical trials. Now, secondary efficacy endpoints is number one is duration of response DOR, which is calculated as date of progression or death minus date of first CR or PR, right? Time to response is TTR, which is date of first CR or PR minus date of randomization. Now, the first response, whether the tumor had not detected or it has completely gone or it has been responded good in a good condition, that date minus date of randomization is time to response. That means how much time did the patient took to get the time of response is in a good condition. The same is the duration of response, whether how much the duration was from the date the disease progressed, that means the disease was worsened, or till the date of first CR, where this date of first CR or PR is nothing but when the tumor was having complete response, right? The disease or the tumor size was vanished, it has been reduced to zero, and the CR and PR, CR is nothing but no disease detected, right? Till that date or some reduction, that means the tumor size has reduced. So that you will be minusing with this date of progression. That is nothing but the duration of response. That means how much response the patients took to get the first CR. That means how much time did it took to get the no tumor detected, right? So that is duration of response. Then next is clinically benefit rate, that is CBR. Now CBR is nothing but CR plus PR plus durable SD divided by evaluable patients into 100. Now you will ask the question is what is evaluable patients? Now evaluable patients will be those patients who are having the oncology or who are having the cancer related studies or who are recruited in the clinical trial study. Now the definition of evaluable patients and non-evaluable patients, it has to be defined in either the protocol or the statistical analysis plan. Only then these formulas will make sense and it will help the biostatisticians and programmers to calculate how many patients are evaluable and non-evaluable from the database. Now next is disease control rate, which is DCR. The DCR is again CR PR plus SD divided by evaluable patients into 100. Now if you see the difference between these two formula is durable SD and this is simply SD. Now this it could be from the clinical point of view, from the clinical benefit, right? So you can specifically you can ask the doctor or like some response person who will be able to explain the difference. Then next is time to progression, TTP. Now TTP is date of disease progression minus date of randomization or death without progression is generally censored, right? So how much time did it took for the disease to progress? That means for the disease to worsen. So that is that they calculate from the date of disease progression minus date of randomization. So it took this much time from randomization to get the disease in progression state. Now, exploratory efficacy endpoints. Number one is biomarker response. Now, biomarker response or biomarker evaluable patients, which is into 100. Molecular response is this is usually based on change in molecular tumor marker burden from baseline. Minimal residual disease MRD is nothing but MRD negative patients divided by patients evaluable for MRD into 100. Time to subsequent therapy TTST is date of first subsequent anti-cancer therapy minus date of randomization, right? Time to next treatment, so date of next treatment minus date of randomization. So from date of randomization, how much time did it took for the new treatment. So how is that calculated? That is calculated from date of randomization. You are minusing the date of next treatment, right? Now these responses, you will have the general kind of description. If you are looking out for some specific formula, you can always contact your sponsor or the doctors who can help you in calculating these response. And because this could be some modern kind of parameters which may be used in the earlier coming oncology clinical trials, right? Now, next is patient reported outcome, PRO based tumor symptom response. Now, this is calculated as number of patients achieving predefined clinically meaningful symptom improvement divided by number of PRO evaluable patients into 100. Next is health related quality of life is proportion of patients achieving a predefined clinically meaningful improvement in validated quality of life score. So in oncology, if you see some kind of quality of life kinds of question and answers, so it could be from that section, this endpoint, or it could be elaborated. Next is exploratory subgroup efficacy analysis. Next is circulating tumor DNA, ctDNA based response. Now this is usually change or reduction in circulating tumor DNA level from baseline. Exact definition is protocol specific. And the biomarker efficacy association. Now these are just the outline of the exploratory efficacy endpoints which I have tried to explain here. Is if the detailed formula, if it is present in protocol and SAP, it helps the other stakeholders to identify this endpoint in a much better way. Now, what are the points to remember here? The exact primary, secondary, and exploratory endpoint classification, it varies on cancer type, disease stage, treatment setting, and trial phase. For example, OS and PFS are common in advanced clinical trials, whereas PCR, event free survival, and the disease free survival are particularly important in neoadjuvant and adjuvant settings. So like say if you have an overall ovarian cancer and a prostate cancer or a blood cancer, or like any other organ kind of cancer kind of a clinical trial study, the disease stage is different, right? Then even the trial phase is different, right? So depending on the phase of the clinical trial study and depending on the disease stage, like say this clinical trial is going to be conducted by recruiting only stage 3 kind of patients, or stage 3 or stage 4 kind of patients, right? Whereas stage 1 and stage 2 patients will not be recruited. So if you have those kind of clinical trial studies, then the objective and the hypothesis setting for that clinical trial setting changes. It will not be same like I explained the earlier slides, but somewhat it has to be there, little bit here and there. So for the exact endpoints and hypothesis, you need to contact the sponsor. What is the sponsor looking in that clinical trial, and what is the sponsor objective is after completing this clinical trial study. So based on that only sponsor can guide you. The next is these endpoints are generally defined prospectively in the protocol and SAP, including censoring rules and assessment criteria such as RECIST 1.1, iRECIST, or disease specific criteria. So either all the specific endpoints, either primary, efficacy, or exploratory, all the endpoints that has to be mentioned in the protocol and SAP. It is not kind of something that the endpoints will not be there. It has to be defined. Otherwise, it will be very difficult for the biostatistician and SAS programmers to take forward. So these are just the basic foundation that everybody should follow. The next is the direction of improvement depends on the instrument. For a symptom severity scale, a decrease is usually improvement. For a quality life function scale, an increase may represent improvement. The protocol and SAP should specify the instrument threshold, assessment window, and missing data rules. Now, say if there is a symptom based scale, then what happens is if that endpoint has decreased, it means improvement. And if there is a quality of life kind of endpoint, then the increase might represent the improvement. So it's vice versa, decrease and increase, right? So in the common layman's language, if a junior SAS programmer or a junior biostatistician is trying to, work on this oncology clinical trial for the first time, and they may not know, like in this specific scale, how come decrease is improvement, and in this specific quality of life scale, how come increase is improvement. So these questions will come if you are just coming out of a college and you don't know how to handle this kind of scales, right? So the only guidance is you need to talk to the doctor who is enrolled in that specific clinical trial study, and that person will be able to help you in a better way, that if this point is decreasing, that means it is good for the patient, and if this point is increasing in this specific endpoint, then it is benefiting the patient. So the doctors will understand very well, and they will explain you in a very common layman's language if you are just a fresher, and if you are trying to understand the oncology points. The protocol and SAP should specify the instrument threshold and the missing data rules. Also, again, what scales, if they are missing, what rule you will be applying, whether the LOCF will be measured or the worst carry forward scale will be used. So those kind of imputation methods also it needs to be mentioned in SAP. Next is subgroup analysis are generally exploratory and should not automatically be interpreted as confirmatory evidence of treatment benefit. The subgroup definition, statistical methods, and interaction analysis should be specified in the SAP. So all these kind of stuffs, like say in protocol, if it is written, exploratory analysis will be conducted, but what exploratory analysis will be conducted, how it will be conducted, what parameters will be used, so all those detailed kind of stuffs will be mentioned in the statistical analysis plan, and it has to be present. Then next is the a biomarker efficacy association does not necessarily prove that the biomarker predicts treatment benefit. To evaluate a predictive biomarker, the analysis generally needs a treatment by biomarker interaction rather than simply comparing biomarker positive and biomarker negative patients. So if you are trying to see if any biomarker, whether the association is either positive or negative to that specific endpoint, then those also needs to be mentioned. Next is oncology efficacy endpoints and their formula are especially useful when working on SAP, TLFs, SDTM, ADAM, and ISS and ISC projects. Now imagine you are working on a oncology clinical trial study. You have mentioned overall survival will be calculated, progression-free value will be collected, hazard ratio will be calculated, but you don't know the formula, right? So even if you're just coming out of the college, it's a first job, it's a first statistical analysis plan, you know that overall survival needs, but how it needs to be calculated, there is no formula mentioned in any of the document. If it is not mentioned in the protocol, that's fine, but it has to be present in statistical analysis plan. It cannot escape from here, because if you don't mention in SAP, the rest of your team members, either your programmers or a biostatistician, who are newcomers, they will not be able to understand the things, because the calculation or the formula is not mentioned. So it is always better to write the formula for each and every efficacy endpoint, even if it's a simple age calculation. Now everybody knows how to calculate age. Still, the calculation of age formula should be there in the statistical analysis plan in the appendix section. In the same way, OS, PFS, and all these parameters, their formula should be mentioned well in advance, so that the later team members, they do not face any difficulty, and it becomes very smooth for them to do the programming in SAS. Many thanks for watching my video and happy learning. Please like, share, subscribe, leave a feedback comment. Many thanks for your support and having great connection.